welcome to the Clerkship Director Boot Camp. So this is the first time we've done this session, so please make sure and provide us feedback on it, kind of what works, what didn't work. We're going to kind of do intros. But even before that, I want to get a sense of who's here. So who's Clerkship Directors right now? So most of what? Sorry, okay. Yeah, so who else is 1 year into, so you're starting your first year. Who else is within the second year? First year? So how about 3 years? Let's look at that. So 3 years. Who's been doing it for more than 5 years? Oh, good. So we got a pretty, and then who else? So those that are not Clerkship Directors, what roles do you guys have?
I'll be transitioning in next year.
Okay. Okay, so good. So we got a good group. So I'm Joe House. I'm the Clerkship Director at the University of Michigan. I'm also one of the Assistant Program Directors there. And then,
yeah, I'm Nick Kman. I'm at Ohio State. I was the Clerkship Director there from 2009 to 2015, and we transitioned into a new curriculum, a 3-part curriculum, and now I oversee Part 3, which is 12 blocks of what used to be the 4th year. We call it Part 3, but so I oversee the entire Part 3 at this point.
I'm Kendra Parekh. I'm from Vanderbilt in Nashville, Tennessee, and I'm our Director of Undergraduate Medical Education there.
Hi, I'm Luan Lawson from East Carolina University, and I have been the Clerkship Director, and now I'm the Assistant Dean for Medical Education.
I'm Adam Nicholson. I'm one of the third-year residents of the University of Michigan.
one of the new chiefs for next year.
Yep, I'm Will Peterson. I'm one of the chiefs at Michigan. I'm doing an education fellowship at Michigan next year and working as Assistant Clerkship Director in that role.
So whose clerkship is required? Yeah, so it's required. So about half. So our goals for this, so we have nothing to disclose. So this is what we want to touch on. Develop some assessment and goals, because we've had, so in the last 3 years, we've had 3 different evaluation forms. So we're going to kind of touch base a little bit on what we've done. And that's actually kind of what I want the residents to touch in on in their respective roles, how well I've done, if I've done well, on training them on the different evaluation forms. We're going to discuss, again, some of the advising, and actually want to get your guys' input on some of the advising for those that have done some. Look at the non-rotator, or the non-EM interested or non-EM rotator, utilizing the instructional goals to try to make it a little more interactive, identify the learning environment, and address student mistreatment. We're going to touch base again on some bedside teaching and describe how the LCME impacts our clerkship. So for those that, again, are new, I started in October, and the LCME for me came the next March. So it was a great kind of getting thrown right into the fire. So again, we'll kind of touch base on how us as clerkships can help or potentially even hurt for the LCME. So this is looking at some of the grading variations. So this is actually looking at all medical schools across the board, not just emergency medicine. So they had 119 out of the 123 accredited medical schools. They actually had 8 different grading systems. So obviously, when you guys get to the advising, looking at grades, and if you guys do anything with the residencies, looking at evaluation or SLOs, there's big differences on what the different grading means. They had 27 unique sets of descriptive terminology. They use the same wording to imply different meanings. And this being like honors, honors plus, satisfactory, satisfactory plus. So again, what does the different terminology actually mean? The percentage of students awarded a top grade ranged anywhere from 2 to 93%. So again, this is because on that SLO, we actually say, what does your grades look like? Because if you're, if 93% of my students get honors and this one student didn't, obviously that's going to really affect what they're viewed like. Versus this student got honors and only 2% of my students get honors overall. There's variations also in between the same school. So 18% to 81% of students getting honors at the same school. Now, again, for us thinking emergency medicine, it's going to vary. It's not as big of a deal. But again, if you're looking at the SLO or you're looking at the applications, if the student got honors in all the rotations except for EM, there's lots of variations potentially there. 97% were awarded one of the top 3 grades regardless of the grading criteria. And again, less than 1% of the students actually failed. Now, the interesting thing about this manuscript when it was published is there's lots of commentary about it. So this was actually someone saying that we should be doing more normative. Well, actually, they're looking at normative versus criterion-based about this variation paper. Saying normative is going to be more of a bell curve. It means you're going to have a few failures every year. So again, obviously, we don't want to fail our students, but if you use that bell curve criteria, you're going to have some failures. versus a criterion base, which is going to skew students more toward honors. So you may not have any failures or less failures. And you actually, is that a successful program if all of your students are doing well? Again, it's going to depend on what your goals are, what the school's goals are. And then this is other things they commented on, the reliability. We need to clarify what each category means. Again, what does honors mean at one school versus another school? They looked at educational theory, and we shouldn't expect uniform grading. So again, me at the University of Michigan, you shouldn't expect the same grade at East Carolina or Vanderbilt or Ohio State because we have variations in patients, we have different teachers, we have a different curriculum. Again, it's harder to kind of normalize that than when you're looking at SLOs and for residency. They said we should really focus more on the mastery-based goals, and we really should eliminate the grade. But, we've discussed that at our school, but then it kind of is, well, what's left up for the residencies? And then you're looking at, your LSME. You're just looking at those numbers and how you've gone from potentially 8 different grades to look at to maybe 1. So again, that's one of those questions that always come up is what about the letter grade if we eliminate it?
So for you guys, are you able to decide on your own how to break down grades, or does your medical school direct you on how that should break down? Anyone want to offer?
Is that what you know?
Yeah.
I meant USU, Uniform Service University, and that we have the overall kind of dean's policy memo, which sets kind of the goalposts for honors and passing, but the department is left to determine what goes into the final grade. So how much weight does the shelf exam versus the clinical eval versus their procedure logs and things like that.
Okay.
So we just get the general guidance from the school in terms of the absolute kind of grade cutoffs, but what goes into the grade is left to the department. And within the department, it's mostly just myself and our vice chair of education, and we just kind of tell the department chair what the decision is going to be.
So at our institution, and Jim O'Brien in the back is a medical student of mine. He's a fourth-year student who's been mandated to sit through this as an SAEM student ambassador.
So if you guys need directions to the next one, talk to him.
But what I tell these guys, our school kind of has a policy where 10% of students are in the honors range, 15% of students are in the letter of commendation, and about 75% of students get satisfactory. And what I tell these guys is, a satisfactory in your emergency medicine rotation is still, a decent score. We always match people at really good places that get a satisfactory. And, because sometimes when the students get their grade, they think their life is over if they got a satisfactory. But really, we try to stick to that breakdown, and it varies every year a little bit. I've struggled a little bit with our Part 3. Neurosurgery, for example, and earmuffs is still a department that students that want to go into neurosurgery get honors typically. We've really tried to kind of rein that in a little bit, but and to be honest with you, very high quality students go into neurosurgery, so maybe they're getting honors, but I've been happy that we haven't had a situation where every student going into EM gets honors. We've tried to stick to that, so sorry to interrupt your...
No, and we actually have ours is 30, 30, 40, so 30% get honors, 30% high pass, 30% or 40% end up getting pass. And we actually increased ours because there was some concern that if we had it cut off at, we were at 20%, so if we have it cut off at 20%, or then hurting our students by not giving out enough of the higher grades. So again, this was actually then a response to the letter to the editor, where they said there should be a national effort to standardize, or the national effort to differentiate students is not worth it, and that we actually should focus more on the low performers, which they identify as that lower 5%. Which then was a response to that response, said we need to focus on the process. We should be transparent, identify struggling trainees, and then value the faculty. And another response, it's because the first one said it was too time-consuming to really try to standardize it, that we should be focusing on those lower students. And there's another one said, it's not too time-consuming. It's not just normative versus criterion, but we do need consistency. And they're talking more about internal consistency, meaning that if you know from University of Michigan this is our percentages each year, then you have an idea and can trust what our grades mean. But again, that's going to be very different depending on what school you're coming And this is actually out of emergency medicine of our data. So faculty evaluations correlated poorly with the medical student examination performances. Not that the shelf exams or the SAEM exam are perfect, but there's poor correlation. And then there's actually, it was on one of the task force, and Luan was as well, and I don't think, but we actually created a national clinical assessment tool for medical students in the emergency department. So try to develop that national end-of-the-shift assessment tool. Now, the one issue that we ran into at University of Michigan is even though I was on a group that helped develop it, I can't use it because there's certain competencies that I need to assess our students on which don't match up perfectly to the other one. So I was actually told, yep, looks good, but you can't use it.
We're actually using it minus one question, which is why we're not enrolled in the group. The last question was a global ranking, and it didn't fit with our competency-based curriculum. So if you're looking for a end-of-student clinical performance assessment or a CPA, the CDEM one I think is great. I would highly recommend it. And I think, I'm not going to speak for them, but I think they're okay with if one question doesn't fit something you want to write, you can use pieces of it. And again, it was put together at court with a bunch of clerkship directors in the room kind of deciding on which questions would be used.
We've actually gone to that as well, and they're trying to record this, so they want everyone who's asking questions to speak into the mic, which I don't enjoy. But what we did is we actually moved that and rolled it out for all of our M3 rotations as well, and we found by having the behavioral anchors on there that we actually got more spread of grades than when we were just using a simple Likert scale and asking people to rate them. So I do think that's helpful in being able to sort of have people identify the behaviors that your students are exhibiting, and it becomes less personal too when you can actually point to the actual behaviors of you did this and this is where you're trying to head to.
So again, why do we do grades? Is it to identify the higher performers? Is it to identify the lower performers? Is it to actually help them obtain residency? So again, thinking about, if it was really the goal to get them all residencies, maybe you are going to be at that higher end for your distribution for grades. Or is it because I have to? It's an LCME mandate. We've got to have grades in by 6 weeks. Med school says I have to do it. Again, there's other reasons as well too. But again, why are we actually doing the grades? And then think about, so what goes into grading? So this is, this is from the Undergraduate Education Emergency Medicine National Survey. So then it's a couple years old. But over 80% of places actually use the end-of-shift assessment. So again, a lot of people are doing these shift assessments. 57% use the written exam. Just over 35% actually had conference attendance, which I actually group into professionalism. So are they showing up on time to their conference? Are they attending the conference? And these are ones that we've specifically done for medical students. We offer the resident conferences, or we have a PZM fellowship conferences, but these are the medical school ones. Again, we associate with professionalism. And then 54% mandated a direct obs. We have a direct observation mandate, but it's because we're one of the core rotations, so we kind of fall under the LCME. We need to have direct observation. Like Nick had mentioned, the medical school direction. So again, ours is 30, 30, 40. So again, that kind of caused us to make these, these splits. And in reality, some of them are very artificial, and there's like a point or less than a point differences between a high pass and an honors. But that's kind of how it's mandated. At the end of the, and the way I've done it is I actually set that standard at the beginning of the year. So per period, it varies. So we may have a period where it's all honors. We may have a period that it's all pass. And Kendra actually has a slide that talks about interest from like the non-EM students, and it kind of goes directly with how our grades flow. And then the other thing they mandated is actually looking at what other rotations do, what the other clerkships do. We don't have to follow exactly what their grading standard is, but they wanted to be some standardization across.
If you see me on my phone, I'm a Twitter person, so that's what I'm doing up here. I'm not texting, but I did tweet out that article, the Alexander article from Academic Medicine, because I think that's an interesting article with the variation.
So again, this, like I mentioned, so beginning of every academic year. So this goes into some of the training and standardization that I've tried to do. The residents can kind of speak if it actually helps or not. But beginning of every academic year, we actually look at the evaluation form. So I actually go to our faculty meeting. We actually have 3 sites. So I actually go to each of our sites. So one's more community-based, one that's more inner city, and then our more academic site. I go to them, I talk about the evaluation form. And then I go to the resident conference, which again, everybody knows how well those are always attended, and try again go over the evaluation form just so people know what it looks like. What we started doing a couple years ago now, and this year we didn't do it because we've had changeover in our admin staff, but actually about halfway through the year, we actually let people know what their grading looks like. So we actually say, here's what your mean score is. Here's what everybody at like the University of Michigan's mean score is if you're at the U of M site. And then also, here's what the mean looks like across sites. So we actually do start a little bit of discussion about, oh gosh, I'm harder than I thought, or well, I guess I'm an easy grader. Not that it actually changes people's grading, because we looked at it pre and post, and there was no difference whatsoever for the most part. But we also looked at it, and most people are still pretty clumped, because we said, if you're one standard deviation above or below that mean, then you're a hawk or a dove. And we had very few people that actually were that far off. So most people were pretty closely clumped, but it does kind of get that in front of like, okay, so now I know how I'm grading. I know how other people are grading. And we actually fed that forward to, so about halfway through the second year is when our residents start working with students. So we actually send that to the second years and say, hey, here's, so they can kind of get some self-calibration on, and how's that going. I don't know, did it affect your guys' grading at all when you guys got that?
Yeah, so the way it works at our institution is that our second-year residents are the ones who are first exposed to medical students, so the interns shouldn't be grading them at all. And then we're coached at that time. I was going to talk about one of the additional challenges we had, which was the change in the grading, the way the grading scale was set up.
Yeah, I've got that on the next slide. If you want to go ahead and talk about it now.
Okay, so just as I had sort of learned the process of grading medical students and come up with my own sort of system of saying, we had this Likert scale from 1 to 9, where 1 was essentially failing, doing terribly, and 9 was outstanding. And so I had this system in place where I said, okay, this medical student seems excellent, so I can put them at about a 7 or 8, which corresponds to the excellent column. I just become comfortable with that, and then the medical school across all clerkships changed the way that they did the scaling to sort of approach more of a milestone-based system. So the anchors, instead of being failing up to outstanding, changed to more like a 5 was functioning at the level of what you would expect of a third-year student going through the rotation at this time. And then a 7 might be, approaching end of fourth year or beginning of intern year. And then a 9 is like an advanced resident or independent practitioner or something crazy high on the scale. So now, if you look at the scale and evaluate and think about it, I had previously been giving these students that I thought were excellent 8s, 7s or 8s, and a lot of other people may have been doing that as well. But now if you look at the scale, that means that they're functioning at mid-residency level. And so then the question becomes, are people adjusting based on the scales, or are they still giving, the same numbers? That's something that Joe had to deal with. But what the solution to that and what he did, which I think had been effective for us as residents grading these med students and becoming familiar with the process, is he would sit us down and say, here's how we look at it. Somebody who's at a 5 at sort of the expected level is probably getting a passing grade, and below that is failing. Somebody getting a 6 who's doing a little better is probably more in the high pass range, and then at a 7 approaching intern level would be more of an honors. And so sort of anchoring then the way that we think about the numbers we're giving and giving us feedback on that. And that helped simplify the process, and I think simpler is better for residents who already are juggling a lot when they're thinking about grading med students. And that helps simplify the process quite a bit, I think.
Yeah, and that's what we try to do is, again, what to expect from students. So actually kind of spell out, this is what I expect from, the passing student. Here's what to expect from, like, that high pass student. Here's what to expect maybe from that honor student. Oops. Where are we going? So, yeah, so this is a new issue that we ran into this year is now we actually have a mix of students. So we're changing our curriculum. So we've got like basically a year, I think it's 14 months exactly, is a preclinical. So instead of your 2 years, typically we're at 14 months. So then kind of in that second year is when they do the required rotations. So we actually will start seeing, so they've done a slow roll. And so like this year, we started getting the new rising M4s, or what we're calling them branch students. The thought being is that there's a trunk everybody does, then there's a branch where you do more professional development. So these rising branch students started in March. So we actually had students that were more or less new 4s and graduating 4s at the same time. So again, how do you balance having those multiple learners at one time? And in some of the evaluation forms, they'd said, if this was compared to their other students, they weren't as good. They were just passing. But in reality, you're not comparing it's apples to oranges, not apples to apples, because you've got someone who's rising who still has 14 months of development before they graduate. versus other students who may have 2 months before they graduate.
So is this a product of a curriculum revision, or is this how things are going to be forever?
So I was saying, from now on in October is when we actually will get our rising students. So eventually, once we get everybody through and kind of get a more consistent basis, eventually it's going to be where during any one block, it'll just be the same level of students. But that's a year ahead. So I can say starting in March, no rising students or no graduating students will be in the rotation. It's all going to be rising students. But again, we're not there yet. Like I said, we still probably have another year or so in advance of that.
Are the students that are coming in the second year required to do surgery and medicine, or are they showing up brand new to the emergency room?
So they're doing this after the core rotations. So they've all finished their surgery, their medicine, their neuro, their psych, their OB, their peds. So they're completing all of that. They actually wanted to make us part of that group. We kind of pushed back a little bit, because the students love our rotation. They love that at the end of the year. They love that they can kind of put everything together. And my pushback was, it's going to be shadowing. If you're a first, I don't know, again, what to call them, that first clinical rotation, they're not going to have that background to kind of determine, some of them still struggling with sick versus not sick, and sending them in to see a patient who has not been necessarily assessed by anybody, but, the triage nurse we had concerns with.
We have a Med 3, what we call Part 2. I'm going to refer to things in the 4 years of medical school because I get confused if I don't. But we have a Med 3 elective. We don't have the Med 3s rotate with us, though, until probably August to kind of circumvent that issue. But I just want to emphasize this all comes down to faculty development, just knowing who the learners are, because you may have a Med 3 in one part of the department and a Med 4 in the other part of the department, and there's going to be different expectations. And what we've done with the Med 3 elective is a lot more formative rotation. I mean, they still go in, they assess patients, but it's a part of a larger ring, and so their grade isn't as important, whereas with the required Med 4 rotation, it's a lot more summative. It's high stakes. They take the NBME shelf exam and those kinds of things. But we have the students introduce themselves as what they are, so the faculty knows kind of who they're working with that day.
And we've actually rolled back our curriculum as well. So we have our M3s and our M4s now start on April 1. And we've actually avoided having overlap. We just lump the block off so that we finish up the graduating students in April and we don't start our new block in EM until May. And then it just keeps it a bit cleaner so that there's not as much confusion.
And we don't have that option. So our school went through a major curriculum revision. And so our third and fourth year students are treated exactly the same. And there's actually no distinction between them. And so we always have third and fourth years mixed together. So it may be a third year's first rotation of their, of their senior medical school and, a graduating fourth year together. And so we really use that opportunity to really focus on the competency. So rather our faculty were always like, well, is this a third year or fourth year? It doesn't matter. What you want to do is look at what you observe in the department and just mark that on the sheet and then let us sort the rest of it out at the back end. And so in some ways it's been a bit of a blessing in disguise because we've really been able to get them to focus more on like what they're observing as opposed to what they would expect of a typical third year or fourth year student.
And that's what we try to do, is basically say, don't worry if it's a third year, don't worry if a rising student versus a graduating student. Here are the competencies. We will make adjustments on the back end. So we will, so we would kind of say in the past, 5, because we've got a 9-point scale, 5 is passing. Anything less than that would be concerning for failure. And now we've kind of said it, well, if you're a graduating student and you're getting 4s, that's concerning. But these early students, a 4 is kind of where we expect them to be. So we have actually made those adjustments. And like Kendra said, the back end, the grading committee, when we look through it, that's how we've adjusted that. So again, this is what ours looks like. Again, 70% is clinical, 20% is exam, 10% is professionalism. So there is some kind of national data on these rubrics and what people are using. We also looked at what our med school was using. So again, there's some standardization, because again, if students see that there's big differences between clerkships, then there's that area, that gray area. That's when you get those concerns from the students about what's fair, what's not fair, how grading goes. So we did try to standardize a little bit. What I end up doing is, so I actually look at last year's data. So for this rising students, this next grading, I actually look at last year's data. I kind of see where those 30, 30, 40 cutoffs are, and that's what I've used for that grading. It's actually been pretty consistent over the last couple of years, so I'm not making much changes. But just again, that's why I use. So that way I tell students, it's not 30% of you guys are necessarily going to get honors, or 30% of you guys are going to get, high pass, and 40% are just going to get pass. It's really kind of, we base this off previous students' experience. If you guys all do great, then they all do well. So I think this year we're a little off on that. I think we're 35% are getting honors. Somewhere around 25% are actually getting high pass, and they're still pretty close to that 40% for the passing range. So that's, again, what we've done for the cutoff, and that's how we determine it. What we've found is faculty are pretty, I think those that have tried to do faculty training, faculty are pretty consistent. No matter how much training you do, there may be some adjustment, but those faculty go back to kind of where they've been. And that's why, again, that's how I use the year-to-year differences versus like an individual class. Because that's how the other school programs for us, they actually, at the end of their year, will look and make sure that, their people are getting the 30, 30, 40, but they're earlier on. So for us, I can't change a student's grade, in August, because the transcript's already been uploaded to ARIS for their slow. So again, that's where we kind of struggle with making any sort of grade changes. So we kind of do it earlier on. And like I said, then we use the grading committee. We review assessments and comments, and that's why we've seen. So on that back end, is looking at all the students and saying, this student numbers-wise maybe is at a pass, especially if it's an earlier student, but all their comments are great. Their comments are more like the high pass comments. Then we bump those students up again on that back end with the grading committee. The other thing we found with our changes this year, for the last period, we looked specifically just at those rising students, and there was a natural cutoff that we had. There was a clump of students that were clearly at the top end. There was a clump of students that are kind of right in that middle, and then we had like one or two students that are on that lower end. So that's, again, how we help determine those students and what their performance is. Like I said, so other issues we ran into. So we actually started out, when I first did this, was a 5-point scale. And then, since we were a fourth-year rotation, we were able to make up our own evaluation form. So we could have actually used the national one. But then they looked at it again and said, yeah, you are, but you're required rotation, so you've got to use the same evaluation form as everybody else. So what we did was, again, using that same 30-30-40 cutoff, is we actually added in a correction factor. So for the first year, we kind of had in there, like I said, a plus whatever it was, 25, because that's what we found was, as we went from a 5 to a 9 point, that was the difference in what our previous grades had been. Then again, this year, again, another change. We went from the 5 categories of medical knowledge and patient care and professionalism and communication, and then an overall. So now we just have an overall. We've gotten rid of those other categories, and now it's competency. So we have about, I don't know, it seems like too many, 10 competencies, I think, and then that's that one overall score that we're using. Nobody knows how we're going to use the competencies. It's kind of like, honestly, like the SVI. No one knows what they're going to do with it, but we've got to complete it. We've got to fill it out, and then we're trying to factor that in a little bit again on that back end with the grading. And again, so what all these changes do, and how do you deal with them? Again, as Nick kind of mentioned, it's faculty development, and you kind of do the best you can. All right.
If I could just mention too, I just want to second what Luan said about the behavioral anchors. We had the 5-point scale for a while too, and I think as faculty we all just had in our head, this student's about a 5, this one's about a 4. But we went to the kind of behavioral base, so takes an accurate history and physical, or history and physical is nearly complete but left out some minor details. These are what some of the anchors look like. If you do that, it's nice because you can picture what the student's doing. It's based on their behavior. The problem is, depending on how they're ranked, faculty still want to pick the 4th one because this student's about a 4. So it really did take going to, so how many people have more than one site? So not as many as I thought, actually. We have 9 sites, and so we have to take the show on the road and go to their, I guess, faculty meeting, their group meetings, and kind of go over, you shouldn't be giving every student the highest anchor, because this is student functioning at the level of a starting intern or whatever it is. So, whatever you decide to use, just make sure faculty understand what the anchors are, and And I would put in a plug for leaving the numbers off, because I think it makes people want to circle 5 for all their students. But whatever you decide.
We actually, for the NCAT EM, because we're doing some validation studies, we're using it as is, but using that as a basis for extrapolating into the 3rd year and what I will argue for the future the NCAT EM should look like. We've actually taken the sort of pre-entrustable language off of it, and we have medical student to resident continuum, and I specifically give instructions to them that the far right side of the page actually lines up with resident like level 2 milestones, and that medical students really for the most part are not achieving those, and that you should really only focus on the behavior. So we're really trying to renorm both faculty expectations of where students should be in the progression, and for the medical students really be able to represent this as a continuum of growth, that this is the direction in which they're headed. It doesn't end there, but that just because they're only a portion through there doesn't mean that they still aren't an honor student, that even students with honors may just end up in the middle of the page, but that's what their expectation is.
Yeah, I mean, other things that we've tried is actually making it so if you're going to score at that higher end, so as Will kind of mentioned, that 7 has kind of been the intern level, requiring that they put comments in there. But, you know, when we started doing that, we've gotten the period, we've gotten the triple X, we've gotten the ABC. So, you know, faculty are finding ways to get around some of those requirements, you know, even the best thing. Yeah. Well, the space doesn't work. There's got to be something in there. So that's why they've learned, like I said, the just kind of hitting random buttons. So this is the part where, you know, we actually want to get, again, people up, moving around a little bit, and kind of, again, do a little bit of teaching each other what people are doing. So we're actually going to look at some advising the students. So there'll be, you know, one of us at each one of the posters, but we want you guys to kind of split up into 4s. So we've got, you know, kind of the not right for EM, low performance in the back, prepare for the SVI, and then kind of the number of EM rotations. And what we're going to do is every 5 minutes we're going to have people rotate. So you're still going to hit each one of those, so don't choose your favorite category. You're going to go to all of them. And then at the end, we're going to try to summarize some of the comments, what the discussions was going on there.